So thank you all for joining us today for a presentation by Dr. Jeremy Hoisak. He will be presenting about current clinical practice and future development in surface-guided radiation therapy. Dr. Hoisak is a fellow Canadian, and he grew up in Ottawa. However, he did his graduate studies at McMaster University in Hamilton, Ontario, before undertaking his graduate studies at University of Toronto in biophysics, medical biophysics. He received his degree in 2011 and then completed his residency in therapy, medical physics in University of California, San Diego, and joined the faculty in 2015. He is a clinical physicist that has a strong research background, and his research interests include automation for quality and safety in clinical workflows, incident learning, electronic brachytherapy, and surface-guided brachytherapy. He also is lead editor of the textbook Surface-Guided Radiation Therapy that was published in 2020. So please go ahead, Dr. Hoisak, and we will, as usual, ask our questions at the end of the talk and put our cameras on when asking questions. Thank you so much.
Okay, great. Thank you for the introduction. And again, thank you to Dr. Maria Popovic and Dr. Shirin Enger for giving me the opportunity to speak with you today about current clinical practice and future developments in surface-guided radiation therapy. So before I begin, I just want to give some disclosures. First, as Shirin mentioned, I am an editor of the book Surface-Guided Radiation Therapy. This was published in 2020 by CRC Press, and I do receive royalties from the sale of this book. Slightly less serious disclosures. I must disclose that my family has a very long history with McGill. So beginning with my grandfather, he was the head of security at McGill University Libraries in the 1950s. Both of my parents attended McGill. My father did his MBA there, and he also played on the football team that beat Queens to win the 1960 national championship. I think he's right there. My mother also attended McGill. She did her bachelor's and master of education. My brother and sister-in-law both studied chemical engineering at McGill. Two of my uncles were professors at McGill in the Education and Natural Resource Sciences department. And two of my cousins attended McGill, and another cousin I think actually works there now. So my only physical connection to McGill is that I was actually born at the Legacy Royal Victoria Hospital just up the hill from campus. Although I did briefly attend McGill daycare while my mother was actually completing her Master of Education. So I do have a small connection there. So this is all to say that it is an incredible honor and thrill for me to be presenting you today with that added family significance. Okay, so getting on to the talk. So the outline of my talk today, I'll begin with a brief overview of the principles of SGRT, and then I'll survey some of the major vendors that are selling this technology and some of the differences in their implementation. I'll then go through the current clinical practice of SGRT, including the major treatment sites and techniques used, and briefly go over some commissioning and QA, and talk about some official guidance that is coming from the various professional organizations. I'll then discuss some near-term innovations in SGRT hardware and software that we may expect to see, and the future clinical applications this will allow. And then I'll discuss some of the current challenges and open sort of perspectives, open research questions and perspectives for the future of SGRT research. Hopefully that'll leave us with some time for some questions. So to begin, the basic principle of surface imaging is that we use non-ionizing optical radiation to image an object. So as opposed to using X-rays to image an object, which uses ionizing radiation, we use optical radiation. So it could be visible or near infrared light usually. So in this approach, we have a light projector shown here, which will then illuminate an object down here, and this will be detected by a camera. Now, the camera and the light projector are a known distance apart, and this can be used to determine the distance to the object. So this distance R for an object at point P. We also use a pattern of light, and this light can once it's projected onto a surface, once it gets distorted, you can then determine the shape of the surface that the point lies on. So we can we can repeat this measurement over all points on the object to reconstruct the surface. So in principle, the resolution of the system depends only on the wavelength of the light and the width of the projected pattern. So in practice, we actually use multiple cameras to image the surface of the patient over different positions. We have, in a radiation therapy room, we'll have this linac here, which will be rotating around the patient, which can potentially block a camera pod. So we'll actually have multiple camera pods. So using that formalism shown here on the left, we have a structured light projector in the pod and cameras. We typically use 2 cameras. This allows us to triangulate the position, again, known with a fixed distance. Like I said, we have these multiple camera pods to account for the fact that there might be occlusion of a camera pod. And also because it is a larger object, you want to be able to see on either side of it. So this pod, this far side of the patient might be hidden from this camera pod. So we'll have another camera shown off of this image, illuminating the patient from over here. Now, to help identifying a specific point on the patient between multiple camera pods, we'll use, I mentioned there's a structured light projection that is imaging the patient. So this can be, there's various types of structured light that can be used. It can be a pseudo-random speckle pattern. This is used by the SRT system, or it could be sort of a grid or more geometric line pattern. This allows us to, this improves the ability to identify a specific point because this pattern can be recognized from multiple cameras and allow it to sort of establish a correlation between the 2 points. Here's an example of what that speckle pattern looks like on the SRT system shown here on the left. This is a black and white photo, but there's sort of a pseudo-random speckled pattern. This is a close-up of the camera pod used by the Vision RT SGRT system. So we have our white light projector, we have a pattern projector, and then, so this white light is sort of illuminating the patient, but the pattern is presenting this speckle pattern. And then we have these stereo cameras to triangulate points on the surface. So there are multiple types of structured light that can be used, that have been used in research. This is a very nice summary by Geng in 2011, overviewing sort of the fundamental principles of surface imaging, separate from radiation therapy. But we can have, we can have sequential projections of patterns onto to an object. You can have continuously varying patterns. We can have stripe indexing. We can have grid indexing. And then hybrid methods that use multiple combinations of these patterns to illuminate the object that is of interest. There's a system for SGRT called the Catalyst, made by a company called CRAD. And unlike the Vision RT system that I showed in the previous couple of slides, they use a sort of a slit pattern for their light projector, which illuminates the object, and then that gets detected by the camera system. So there are multiple vendors of SGRT systems, but they all use slightly different surface imaging principles to image the patient. So once we have the patient illuminated and there is that speckle pattern on the patient, that can be used to sort of reconstruct the surface. The next step is to convert that sort of video image of the surface into a mesh that can be used computationally. So generally we have a triangular mesh that is formed to represent the image of the patient. Now the size of these triangles in the mesh and the distance of the points of these triangles from each other will sort of determine the accuracy of which we can model the surface that's of interest to us. So for smaller treatment sites, for example, it's like the head or the neck, we'd like to have finer details, like the nose or the ears or even the eyes. So you'll want a smaller triangle mesh. If we're imaging, say, the chest or the pelvis, we'd like to have, there aren't as many features, and so we can use a larger mesh. So the resolution of this mesh will matter both for tracking accuracy and sensitivity of the system to position, as well as intrafraction motion that we want to detect. So this live video surface image is then converted to a surface mesh. For tracking purposes, we'll actually define an ROI. So we won't actually track motion within this entire image surface mesh. That would be very computationally demanding. So the user will define an ROI over an area that we want to track in particular. For in this case, we've drawn an ROI around a breast. And then this imaged mesh or computed mesh from the video of the surface is then compared with a typically DICOM data, which can be imported from a planning CT. So we can, if a patient undergoes CT simulation, we will then export that DICOM file of their body contour. This will be imported into an SGRT system, and this serves as a reference to compare to the live video feed. And I'll show you that. So if we have a larger mesh, I mentioned it requires more computing power, and this can in turn affect the latency of the system. So if we have sort of quick movements, they may not get detected at all because the system just can't respond in time. So it's always a trade-off between the size of your mesh and the treatment application. So I had mentioned that we use the CT body contour, which is obtained at CT simulation. This serves as a reference. This is exported to the SGRT system, and then it can be loaded up in users' control system shown here on the right. The patient will then get positioned on a treatment table, and then we will take a live image of their surface. So in here in magenta is the CT or the reference surface, and in green is what the SGRT system is actually imaging. And this will get displayed to the therapist as a calculation of offsets in 6 axes, so vertical, longitudinal, lateral, and then yaw, pitch, and roll, with a total overall magnitude displacement. And so they can apply manual adjustments to the patient, or they can move the treatment couch to bring the patient into alignment as these displacements are updated in real time, and then you can set thresholds as well, depending on the treatment site. Once the patient's in position to their satisfaction, they can obtain a new reference of the patient in the current position, and that can serve as the reference from which they calculate these baselines for the remainder of the treatment. So if the patient moves during treatment, they can detect that and bring them back into the position they initially set up. Alternatively, once you have that baseline, you can measure things like taking a deep breath to guide certain radiation therapy techniques that use breath holds. And these thresholds for detecting motion, this can either be just manually configured to sort of halt a treatment beam if the patient moves, or they could be automatically gated if you have a connection between this system, SGRT system, and your linear accelerator. So as I said, there's many vendors of SGRT systems. Shown here are a few. This right here is the Align RT system. This was the first commercial offering for an SGRT system. They use 3 camera pods mounted around the treatment room. Here's the linear accelerator, there's the patient. And so there will be a display similar to this display here that will show the therapist how the patient is aligned with respect to their reference setup. Over here is the Varian Identify system. This is similar to the Align RT system. We have ceiling mounted SGRT surface imaging camera pods. The Varian Identify system also uses a time of flight camera mounted on the ceiling to image the patients on the couch and all of these different accessories. And this is sort of a newer innovation. It allows the therapist to see if they've placed the accessories correctly, not just the patient. Down here is the Catalyst made by a company called CRAD. They work closely with Elekta, so you tend to see those with Elekta systems. And then Varian and Align RT used to work closely together, although they are cross-compatible. You can use them with either one. CRAD is similar to Varian in having the ceiling mounted pods. And then a new vendor is called the BrainLab ExactTrack Dynamic. So BrainLab makes a stereoscopic X-ray guidance system, usually used for intracranial and lung applications. They've recently come out with a third sensor system to add to their X-rays that takes not only surface imaging, but also thermal imaging. So they've got a thermal camera mounted in here with their camera pod. So they're, like I said, they're the newest vendor. Their innovation is to add this camera pod. They've got the stereoscopic surface imaging cameras, the illuminator, and then this thermal camera. So the idea behind this thermal camera is that they can increase the number of features available to perform a match between your surface that's imaged and your reference surface. So if you have a very flat surface, such as the abdomen, there may not be many features, and you can have sort of a uncertain matching between your real-time surface and your CT or reference surface. So by adding thermal information, they can increase the number of unique features and improve the matching. And this is useful not only with, say, the abdomen, but it could also be used for cylindrical or symmetrical surfaces such as limbs. And it's kind of exciting to have this thermal imaging system built in, because it's not unreasonable to think that maybe we can use this thermal imaging system for other applications, perhaps the biometric monitoring of the patient's temperature. You could use it for screening. Maybe you could even image blood perfusion of the skin surface, or monitor for treatment effects like radiation dermatitis or impaired lymphatic drainage. They haven't said that's what they're going to use it for, but I think it's just interesting to be adding extra sensors in addition to the surface imaging systems. Another interesting use of SGRT systems is for in-bore systems. So there's a tomotherapy is sort of a gantry that's built into a sort of so it looks like a CT scanner or an MRI. This here is the Varian Halcyon, which is also what we call a bore type gantry. So the gantry is actually within here. It's the linear accelerator rotates around the patient, similar to the way a CT scanner will rotate around the patient. Because it's entirely enclosed, the patient's not visible, so it's difficult to actually do SGRT with this system. This is work by my former colleague Everardo Flores Martinez and Dr. Grace Kim at UC San Diego. They developed some methods to account for the fact that there's this bore obscuring the patient from the SGRT camera pods. Their solution was to place the patient, basically do setup of the patient on the couch here at a virtual isocentre, and then the patient gets translated into the bore, and then that is a known translation, and then they would proceed with treatment. They were unable to actually image the patient inside the bore because they weren't entirely visible. Fortunately, AlignRT came up with a solution to address this problem by placing a SGRT camera within the bore itself. And I'll show you that right here. So this is what they call the AlignRT in-bore. It's actually a plastic insert. It doesn't actually change the linac in any way. It just sort of snaps in place and it gets external power. They claim that an engineer can do this in just a couple of hours. It doesn't sort of require you to open up the gantry at all. So it is an interesting solution. So what happens then is that we have the patient set up on the treatment couch using these external ceiling mounted camera systems, and then the patient's translated into the treatment position, and this ring system will then monitor the patient for treatment. The CRAD company that makes the Catalyst system, they have their own in-bore system. Their solution is to actually have an additional camera at the other end of the bore, which is imaging into the gantry. So there's alternate ways you can actually achieve or work around this problem. Okay, so that's a survey of SGRT principles and current vendors. It originally, in terms of clinical applications, SGRT started out mainly for guiding stereotactic radiosurgery, as well as guiding deep inspiration breath holds for sort of left-sided cardiac sparing and breast treatments. But it's evolved into a widely used tool now with application to many disease sites. So including treatment of, I mentioned SRS and DIBH, but extremities, stereotactic body radiation therapy. SGRT systems can be installed into CT simulation rooms to allow respiratory correlated CT, because we can track the rising and falling of the patient's abdomen. Building off success of SRS, it's been applied to minimally masked head and neck treatments. A really exciting development is that it can enable tattoo-less patient setups, and I'll go over that in a bit. And another great application, because it uses non-ionizing radiation, is that we can use it for guiding pediatrics. So I'll just go over some of these treatment sites in more detail. So like I said, frameless stereotactic radiosurgery was one of the very first applications of SGRT. This is work by my former colleague, Dr. Laura Cervino at UC San Diego. She described our initial clinical experience with using a frameless and maskless stereotactic radiosurgery treatment. So conventionally or historically, stereotactic radiosurgery used a sort of a very extensive fixation device, which may sometimes involve pins actually surgically inserted into the patient's skull, or with very, very rigid fixation masking systems, which can be quite uncomfortable to the patient. And very difficult to actually do fractionated treatments if you have to have this very invasive frame. It sort of limits you to single fraction treatments. So at UC San Diego, we developed a system that used no frame and initially no mask at all. So we would just position the patient's head using the LINRT. They would just have a head mold, and then we would have this CT scan and the mesh. We define an ROI. We found that we had to actually exclude their eyes from the region of interest, because if they blinked, the system would detect that as motion and cause spurious offsets. Ultimately, though, we originally started out having no mask at all, but we eventually settled on having a very open mask that sort of restrains the forehead and chin. So in this process, the patient undergoes, as I said, CT simulation, they create the mask and the cushion. We plan the treatment in our treatment planning system, export the body contour to the SGRT system to find the ROI. And then we position the patient on the couch, like I showed you in this previous slide, using the offsets to guide us. Then we capture a new reference once the patient's in our position that we like, and then we proceed with imaging as conventionally done for SRS. So we do a CBCT to do an alignment of the target to our satisfaction. Then we capture an additional reference surface once we've got that CBCT in place. And then the SGRT system provides monitoring. And the nice thing about the SGRT system is that we can monitor the patient's position at non-coplanar couch angles. So if the couch is at 0, you can use your orthogonal x-rays or CBCT to image the patient. But if you move the couch to a different angle, say 90 degrees, you can't really image that. So the SGRT system allows you to monitor the patient's position in real time at all couch angles. Another major application of SGRT is for guiding deep inspiration breath holds. The main advantage of deep inspiration breath hold is that when I take a deep breath, the anatomic position of the heart will actually change inside the patient's body. So here is a sort of a normal heart position. When they take a deep breath, this will sort of drop the diaphragm, and the heart will drop as well. So here you see the heart moving inferiorly. Here's an axial slice of a treatment plan. You can see here a free breathing plan with a breast irradiated with tangents sort of across here. When the patient takes a deep breath, this heart actually moves inferiorly, and it looks like it moves away from the chest wall. So what we're actually doing is sparing this heart from getting any radiation. And the risk of heart disease in women after getting radiotherapy is quite significant. We generally try to limit the dose to the heart as much as possible. And so deep inspiration breath hold is a really helpful tool in sparing the heart from getting unnecessary radiation for patients treated with left-sided breast cancer. There's been many studies in the literature to evaluate the reproducibility of breath holds because if you try and imagine yourself taking a deep breath, you can take different depths of breath. So the real challenge is to try and get the patient to breathe to the same level every day. And that's where SGRT can really help. So here's just two examples of breath holds being used on, this is the Variant Identify SGRT system. This is the CRAD Catalyst SGRT system. In this case, the patient is actually wearing video goggles, which displays, almost looks like a video game. So the patient is given this sort of green box, and that is their target. And they have to take a deep breath such that this orange bar will reach the green box. And so the orange bar is a factor of the SGRT system monitoring their abdomen. In the case of the Catalyst, they're actually monitoring the position of this red circle right here, whereas the Variant Identify is actually imaging a much larger surface area to generate this respiratory trace. The patient may have coaching, I think, in the Variant Identify system as a sort of a larger screen. Not all patients like having the video goggles. They can find it claustrophobic to have their vision blocked from the outer view of the treatment room. But this could be a generational thing. Maybe younger patients will prefer to have video goggles versus something else. You can also do audio coaching. At my clinic, we actually don't use video goggles. We just tell the patient when to take a deep breath. And then when they reach that level, we say, great, hold it there. And then we can monitor that with the SGRT system and deliver the radiation when they're inside this sort of deep inspiration window. There are many other sites that we can treat with SGRT. One of the interesting ones is extremities. So for patients with, like, for example, sarcoma, we may have the lower limb or upper limb. This is really challenging to treat with conventional imaging. To get the position just right can be quite tricky. What might happen is that we'll position the arm or the leg and then take an X-ray, find that we need to adjust the position. Maybe you have to roll the limb, maybe you have to rotate or change the position. So it's much harder to position reproducibly than, say, the abdomen or the pelvis. The advantage of SGRT is that you can do all of these adjustments in the room while the patient is with the therapist in the room. You don't have to go in and out because you're taking X-rays. And that can really make the setup process more efficient and save a lot of time. It can also reduce the amount of imaging you need to take. You don't need to take 3 X-rays to get that limb position just right. You can sort of align it initially with the SGRT system quite effectively, and you may only need 1 X-ray. One challenge, though, with extremities is that you can have these very cylindrical, uniform surfaces, which are hard to get a good match. And so you have to make sure you get some geometrically unique features, such as just a bit of the ankle, a little bit of the knee, or with some sort of a curve. I mentioned using SGRT for deep inspiration breath hold. You can also use it for guiding other gated treatments, such as lung treatments. So we can't image the lung or lung tumors. They're not directly correlated to the surface of to surface motion, but you can detect the motion of breathing, which has been correlated with motion of a tumor. So we can image a part of the chest or abdomen, we measure a breathing signal. Or if we're doing SBRT for example, the spine, where you don't care about the respiration, we can image more fixed anatomy, such as the rib cage, and that can give you a nice tracking ROI. For example, high dose treatments such as the spine SBRT. So the respiratory correlated CT is another application that we can do in the CT sim room. So instead of having these camera pods on the ceiling of the LINAC, we can have a single pod in the CT sim room to track respiration. And so this isn't to gate the beam. This is actually to reconstruct either a respiratory correlated CT or to guide a breath hold. Shown here, the breath hold. And so we can then generate a 4D CT where we have sort of a CT scan performed at each phase of a patient's breathing. And this can be used to help define various treatment volumes for use in respiratory correlated treatments. This is work by my colleague, William Song at UC San Diego. He evaluated the GATE CT, which is the commercial name of LINRT for 4D CT. He compared it with the Varian RPM camera system, which is sort of Varian's, it's like an infrared marker block that's placed on the patient's abdomen, and that sort of provides the respiratory signal. They found comparable performance. Moving forward. But they did found it had several advantages when you use a LINRT system or a surface SGRT system for the respiratory signal. So we're less dependent on where this RPM block is placed, which can vary the amplitude of the respiration signal you get. And by having a more robust correlation or reproducible amplitude of the signal, we can have less artifacts in the CT scan from how we reconstructed that 4D CT. And this again translates into more reproducible breath tracking at the treatment machine. Based on the success of the minimally masking SRS treatments, several investigators have studied using open masks for head and neck. These can be more comfortable and less claustrophobic. And they also allow you to test the designs of these systems on volunteers without using ionizing radiation. So there's some interesting work by Zhao and by David Wyatt on using open face masks for head and neck. Really exciting application of SGRT is to forego the use of tattoos and skin marks on the patient to do setup. So SGRT allows us to do CT simulation without actually tattooing the patient, these permanent marks that we place on the patient's skin to guide their setup on the treatment day, which we use with light fields and lasers. So they may have permanent tattoos. They may also just have markers placed on them to help align them. And aside from being painful when these tattoos are applied, they can also have negative psychosocial effects, and that patients will remember that they had cancer and they had radiation and may have been a traumatic experience, and they have these tattoos as a daily reminder that they underwent this. Some people have studied using foregoing the use of these tattoos. This is the work by Stanley et al. They looked at various treatment sites, comparing 3-point setups using tattoos and surface imaging only. And this is before taking any X-ray imaging with the cone beam. And they found, they looked at, I think, over 6,000 different fractions of treatments, and found that overall, the 3D shifting corrections for patients initially aligned with SGRT were significantly smaller than those patients that were aligned with skin marks. They did this for several sites, including the pelvis, abdomen, the chest, and upper extremities, in addition to the breast. And so they found that those magnitudes tended to be, of shifts tended to be smaller. So you can see here the red, the surface imaging shifts, the magnitudes are smaller. And they had less frequent large shifts. And so this translates also into just faster and more efficient setups. SGRT is ideal for pediatric applications because it uses non-ionizing radiation. Also, we can forego the use of tattoos and skin marks, which obviously we don't want to be doing that on our patients. Here's some examples of pediatric imaging. Often these patients require anesthetic because many children cannot, either they can't stay still or they don't understand why they have to stay still. And so they may need to be sedated in order to be treated with radiation, particularly for certain techniques that have longer treatment times. So when we do that ROI definition on the for the SGRT tracking, we have to make sure we exclude some of their anesthetic tubing and other life support systems. However, because we can use this SGRT system to monitor their position for older patients, older pediatric patients, it may be that anesthesia isn't even necessary at all. It could be that we can actually do the setup so efficiently that we don't need to worry about this. We can also use SGRT for proton therapy. Here's an example of using SGRT to improve the efficiency of proton therapy. This is work adapted from Batten et al. They looked at a series of patients where the first 5 were treated with X-rays, used X-rays to set them up, and then they used surface imaging to set them up. And they found that SGRT reduced the time required for setup quite a lot, from 11 minutes down to about 6 minutes. It also, without really impacting the total time required to deliver the treatment. So SGRT is quite a useful tool, not just for accuracy, but also for efficiency. This is internal data from Hania Al-Halak from University of Chicago. She found that SGRT reduced the required shifts to get the patient into alignment. It reduced the amount of imaging required and the total treatment time. So she looked at 100 patients, 50 with using tattoos and skin marks, and 50 just using SGRT in addition to that. And so they lowered the degree of shifting required to get the patient into alignment, as well as the total treatment time. So this just shows that SGRT can really boost your efficiency. So when used on all patients, not just a very specific niche of patients such as SRS or DIBH, SGRT becomes a really effective quality and safety tool with broad benefits across the clinic. We can think of SGRT as almost a qualitative second observer of all treatments. So there was a study by Ezel et al. Looking at the radiation oncology incident learning database. They found that 44% of all errors in that incident learning database were related to wrong shifts and incorrect localization of the patient. Hania Al-Halak also did her own study of 3 different incident learning databases and found that 21% of common radiation therapy errors could be prevented by using SGRT. So used for all treatments, it becomes a sort of a routine quality and safety tool. And in fact, newer SGRT systems can actually detect incorrect or misconfigured accessories or bolus placement, and may even be able to help identify the patient based on the surface imaging. So here's a screenshot from the variant identify, which can be used to identify if the patient has been configured on the table correctly. I will say, though, that SGRT can introduce new error pathways that may have been not necessarily there before. One of the major error pathways for SGRT is that you can import the wrong CT surface. So you can imagine that would be quite bad for trying to localize the patient. And then a sort of a subtle, a similar error to importing the wrong surface is may not be the wrong patient, but you may import, say, if you're looking at a deep inspiration surface versus a free breathing surface, you could import the wrong one or get them labeled wrong. Another potential error pathway is just failure to track. So you could have your SGRT system tracking the patient, and it could be that the patient is moving, but the system is not updating to show that movement. So failure to track is actually a major failure mode that was identified in this work by Manger et al. He's my colleague at UC San Diego. They looked at, did an FMEA for SGRT applied to SRS. And they found that SGRT did not actually significantly increase the risk when using it for a LINAC-based process. So now I'll just quickly go over some SGRT commissioning and QA. So SGRT commissioning, routine QA is mainly daily and monthly, and then some sort of pre-treatment QA, which can be done on days where you're treating the patient. This is a calibration board used to align or calibrate the system on a daily basis. Some commissioning tests when setting up an SGRT system include evaluating safety interlocks, evaluating ambient light conditions, calibrating the camera pods, evaluating their static accuracy, quantifying the field of view. We have phantoms to measure isocentre coincidence, both with the linear accelerator, the surface imaging system, as well as the KV imaging systems. Thermal stability is an important thing to evaluate on SGRT systems. They do take a while. They could take about 20 minutes to achieve thermal stability. And you can actually see a change in accuracy of these systems as you can see almost like a drift as the camera system warms up. Camera blocking, which I mentioned earlier, is important to quantify if you have a rotating gantry or other accessories in the room. Looking at the effects of ROIs and the size and how dependent the system is on the size of the ROI is important. In addition to static accuracy, we need to evaluate dynamic accuracy, evaluate connectivity with your treatment planning system or the CT, so we can import and export DICOM. And ultimately, any commissioning should end with end-to-end testing, where we test the entire workflow, both from imaging a patient, setting them up on the table, delivering a treatment, and then monitoring treatment throughout using SGRT. And then there may be application or site-specific testing, such as, say, we have to add an in-bore system. For daily commissioning, we use this calibration plate. This is placed on the LINAC couch. The light field is used to illuminate it. And then there's software. This is an AlignRT software, where we image these known blobs where their orientation and distance from each other are known. And the software can then establish a spatial correlation between cameras using this calibration plate. So all three camera pods are looking at the same plate, and this allows us to ensure that they are correctly calibrated. Monthly QA utilizes a phantom, typically has a hidden target within it. So in this one, we have a cube phantom, which is compatible with surface imaging. And then we have spheres within. One sphere is located at the center, and then the other four are located asymmetrically around the sphere. We can then image that sphere, or sorry, that phantom with the SGRT system, and then take, in this case, MV port images at 4 different angles, and then do a radiographic analysis, and that can provide a isocentre calibration for the linear accelerators isocentre and the SGRT system isocentre. This is typically only done monthly or even quarterly. And then before all treatments, especially if we're using SRS, we're doing SRS with our SGRT system, we will do a Winston-Lutz test. So these are images from my colleague Grace Kim at UC San Diego. This is our existing Winston-Lutz phantom, and we added a little face mask to it to sort of provide an SGRT surface. So this surface imaging compatible phantom is set up on the treatment couch. There is a tungsten target in there. The phantom is aligned using the surface imaging, and then we obtain MV port images of the tungsten BV at multiple couch and gantry angles. We can calculate our magnitude of our radiation mechanical isocentre In this case, it's 0.4, which is within our tolerance of 1 millimeter. And this is typically done monthly or before any SRS treatment. Another pre-treatment QA test that you can use with SGRT is to do sort of a pre-treatment collision test to make sure that there will be no collisions between the couch and the gantry, and you can use your imported surface to help guide that, to make sure that there's no risk to the patient of these moving gantries and couches during treatment. There's numerous guidelines, either available or in development. Astro wrote a guideline on continuous localization technologies in 2012. AAPM has task group 302. Their report should be out soon, and hopefully in 2022. And Estro is also working on guidelines for surface-guided radiotherapy, and I think it's a bit of a race to see which of these two groups will generate their guidelines first. But this will go over all aspects of commissioning, QA, and clinical guidelines for use. So I'll just quickly go over some interesting future applications that may be coming for SGRT, which I think are particularly interesting, including biometrics, collision detection, augmented reality, and then the role of SGRT in adaptive therapy. It may even have a role in treatment response monitoring and dose deposition monitoring, which is actually really cool. So several SGRT vendors have patient ID systems built into their larger constellation of devices. So mostly these are facial recognitions, similar to, or palm scanners, similar to what you might see at an airport or other security systems. However, SGRT cameras actually are able to distinguish patients based on body surface features alone. This is work by Wyant et al. He looked at surface features, and he was able, through this histogram of surface statistics, able to distinguish different patients from the same patient. And using different thresholds, you can sort of identify a threshold for identifying if it is a particular patient or not. So you could imagine that if we moved away from sort of palm readers and facial recognizing scanners, if you place the patient on the couch, the system could potentially say, hey, this is the wrong patient, this is the wrong body. One potential problem, though, is if you place a patient in a different body position, that could create a false negative. But by applying an appropriate statistical threshold, you can address this. Some have been using SGRT to evaluate other patient biometrics, including respiratory monitoring. This is work using SGRT system in a ICU. This could also be used in radiation therapy for doing motion correction for CBCT, or maybe just doing a general respiratory assessment of patients who are on treatment. Cardiac monitoring has been done with surface imaging cameras. Prochaska et al. Used a commercial grade camera to image the pulsation of the skin surface. So this actually had excellent agreement with a Garmin heart rate monitor. So one can imagine this integrated into SGRT systems. We could potentially monitor patients who have implanted cardiac devices, or just have one additional data point to measure on patients who are on treatment, particularly if they're having perhaps left-sided breast irradiation. So I mentioned collision detection earlier for SGRT, but it doesn't really, that's more for anticipating detections. One potential application of SGRT is for real-time collision detection, especially if we have imaging arms that are moving around the linear accelerator, or if they're doing initial patient setup. This could be a system that's always on and just watching for a potential accidental collision as they're just maybe moving the patient into position. So collision detection in sort of prospectively using the CT data set is limited to the scan range of the data set that is used to generate that CT body contour. However, SGRT actually has a very large field of view. In fact, it has the largest field of view of any imaging modality used in radiation therapy right now. So you can image not just the patient, but any accessories, arm position, the couch, other objects. So this could be something that's always on and alerts therapists that they are about to move the gantry into perhaps the patient. And this does happen, particularly if therapists take their eyes off the patient because of some other distraction. Augmented reality has been proposed. So right now, therapists are looking at that display that shows the offsets. It also shows them how the patient is aligned relative to the reference surface. But there has been some work to see if therapists could be wearing goggles, which are displaying that information. In this way, they have their offset information shown to them without having to take their eyes off of the patient. So that is a potential big safety improvement. However, one downside is that everyone has to be wearing goggles. Otherwise, only one person can really see that shift information. So it's not entirely clear if this will be popular with therapists or not, but it is an interesting application. And another, I think we're going to see this quite a bit, is SGRT can be used to help adaptive therapy. So adaptive therapy is where we adjust the treatment plan for weight gain or weight loss, or maybe tumor growth or shrinkage. And in online adaptive therapy, patients' plans are adapted on the fly with the table on the couch. And this can be quite lengthy. It could take up to 30 minutes or even an hour. And so we don't want to be doing X-ray imaging to make sure that they're in position all this time. So SGRT will be essential for monitoring patient setup and position when doing adaptive therapy. But I haven't seen any research on this yet. Here's just an idea. Here's a surface imaging camera that's handheld, which can be used to evaluate skin condition. So we can imagine an SGRT system could potentially be imaging skin condition to identify if they're getting a radiation dermatitis or if we need to discontinue bolus use. And a really cool application is in vivo dose deposition monitoring. So this is a SGRT system that has a Cherenkov radiation detector integrated in it. And this can actually detect emissions from deposited radiation dose. So shown here is imaging of a leg, and they can look that the dose has not gone into a contralateral leg. Here is an example of a chest wall irradiation, and we can see dose deposition into the patient's chin. So this provides real-time verification of dose deposition. And so a company called Dose Optics has developed this. And so they're, like I said, they're using it to verify dose distributions and avoidance areas. It can also be used to evaluate field match lines. So this is pretty exciting, and we may see this in more SGRT systems in the future. So I'll just quickly summarize with some current challenges and open questions for SGRT. There are some challenges and some fundamental limits to the technology. It can be hard to make a business case, though, for this technology. And really, we want to know, has SGRT improved outcomes? So there are some fundamental challenges for SGRT technology. One of them is that we need to image the patient's skin. That's not as useful if the patient is wearing clothing. And this clothing can both block the accurate imaging of the surface, or it can actually obscure that speckle pattern I talked about way at the beginning of the talk. So here we have a patient with dark underwear, which actually creates a void in our tracking area. Lack of distinct surface features can be a challenge, especially for uniform surfaces or symmetric surfaces like limbs. We can have occlusion of the camera by equipment. So when we move the gantry over here, it could be blocking this camera pod. We could also move the couch, and that could actually make the chin block more superior parts of the skull, so that we can have self-occlusion. And so we need multiple camera pods, but this still isn't a perfect solution. More fundamentally, the correlation of surfaces to deeper subsurface targets is questionable. So we kind of are limited in using SGRT to more superficial treatment areas like the breast. So SGRT may not be as useful for treatment of, for example, the prostate. So SGRT is no longer just a niche technology. It can play a role in treatment of every patient, not just DIBH or SRS, with wide-ranging benefits to treatment quality and safety. I showed you some innovations and potential future applications that are only going to make it more valuable. But it remains that SGRT systems are very costly, and it can be difficult to make a business case to governments or hospital administrators. I think in the US, there's only about 50% of US clinics have an SGRT system installed. And in Europe, this is about 20%. And I believe they're much less common in Canada, where cost concerns may be limiting their adoption. But it could also be a criticism of SGRT is that it adds little to patient outcomes, or that the outcomes data isn't there yet, or that it's redundant to IGRT. And this is a criticism I've heard quite a bit, that SGRT adds nothing that you can't get with X-rays. So to address that criticism, it's interesting to point out that IGRT faced a similar question when it was first introduced. There was no evidence that IGRT was improving outcomes either, but we just had to wait for the data. So here's just a little graph to show that outcomes are a factor of many different factors. So it's very hard to point to one specific piece of technology or technological innovation which produced an increase in patient outcomes. So it will be hard to sort of point at one thing and say SGRT improved outcomes. So, but studies are underway. So cardiac sparing with DIBH, outcome studies with SGRT guided intracranial SRS. Here's a summary of all the different radiosurgery papers using SGRT have shown using it for brain metastases, benign skull tumors, trigeminal neuralgia. As I said before, there's quality and safety benefits from using SGRT and psychosocial benefits from using tattoo-less setups, not to mention reduced dose from imaging, especially in pediatric patients. So SGRT can be used for most anatomic sites with wide-ranging benefits. Future developments are going to leverage, I think, the vast surface data that we're acquiring with every fraction. So we may be able to do direct patient recognition, enhance biometric information, or use it to guide adaptive therapy. There do remain fundamental challenges to surface imaging, including that surface to internal target correlation, camera occlusion, and just the presence of gowns. However, SGRT is the only modality that is always on. It acquires in real time, has a large field of view, and does not use ionizing radiation. So it definitely has some unique attributes which make it very useful in the clinic. So I like to think that SGRT complements IGRT. It does not compete with it or aim to replace it. So the impact of SGRT on patient outcomes is potentially wide-ranging, and the evidence from clinical trials is sure to come in the near future. So with that, I'll thank my colleagues. I have some colleagues at UC San Diego and the wider SGRT community who helped with this talk. And again, I'll thank Dr. Popovic and Dr. Anger for the invitation to speak with you today. So I'm happy to take any questions you have. I've also got my email and Twitter account here if you want to.